Okay. Visual acuity 62466, daytime examination. Entry with results, right eye. What do you think and what is the process going on through your mind at this stage?
From the history, he compared plotters and then show all the examination, but it's quite different. Is only the anterior vitreous, there is a stress of cell. In anterior, there is no cells, no flare, and quite. I think it probably intermediate uveitis.
That's a good thing. And yeah, you are thinking in terms of intermediate uveitis. Anything from the history will help you again to think about?
He has a history of scratch by the cat, and also one treatment in rheumatoid arthritis.
Okay, so?
What was the age?
40. So what would you like to do next for this?
Okay, the posterior segment.
Posterior segment examination. Okay. We'll do posterior segment for you. Okay. Lynn, posterior segment.
Okay.
Quick.
I guess. Can I guess?
No, first describe. Do not, again, as Professor Gupta has also very clearly said, go for a morphological diagnosis, do not jump for a etiological diagnosis. First describe.
I see swelling of this.
Yeah.
And also.
And I'm sitting in another country, you're sitting from another country, but you are describing to me. And I'm not seeing any picture.
Okay. We can see the frontis reflex, and then the optic nerve is blurry. We can describe the age. It is because of the swelling.
Okay.
And then arterial and venous is look fine.
Okay.
And then the macula, I saw macular star.
Okay.
Even it's not clearly so all the macula is photograph of.
Call it a macular fan, because
macular
when you
fan,
talk of
okay.
the macular star, it becomes another etiology. This is
It's
the fan.
macular fan. Okay.
Then what else you will like to examine? I'm listening, I will ask you something.
The FFA.
No, you haven't finished the examination. You have not seen the periphery of the eye.
Okay.
You have to ask that. What is the periphery? Because that's very important in a comprehensive examination. What is the fellow eye?
Oh, yeah.
You have not asked me what is the status of the other eye. Because a lot of times you can get clue. So these are the two important things every time missed out. If this kind of 45 degree or 30 degree fundus picture is shown, every time you must ask what is the periphery, is there anything going on wrong? Because that is what reflects in your clinical practice. You are not going to just stop, okay, that's it, done. Okay, and then, okay, periphery is normal, other eye is normal.
Okay.
So, next.
Next, FFA.
FFA? Why? Why you want to do FFA?
Actually, can I guess based on this?
Yeah, you can get for a working diagnosis.
Okay. My working diagnosis, based on the history, I guess this is ocular toxoplasmosis.
Ocular toxoplasmosis.
Based on the history and what I see in the posterior, it's really, I've seen this case before, but I'm not sure, but it's sort of like this presentation.
Professor Gupta she is with you. How will you take her through now?
Yeah,
Yeah.
So,
now next.
If I have to have the other mic, yeah. Now, if I have to evaluate this patient, and as you rightly said, your description has to be complete. Okay. So first you start with the media. Okay. We did see some trace cells, Because yesterday I think there was a discussion on sarcoid affecting the optic nerve head when you were discussing that.
Yes.
Right? So the clue to the possible sarcoid etiology is the presence of cells. Look, the differential is always like patient has also hypertension. You know, patient may have had raised intracranial pressure. And how do you reach the diagnosis of, sarcoidosis? So hypertension by no way or intracranial pressure would cause vitreous cells. So if you see vitreous cells, raised intracranial pressure, and some of the papilledema or tumors or other intracranial pathology is ruled out. But if you have intracranial pathology and vitreous cells and eye pathology and there's eye inflammation, we are thinking in terms of inflammatory pathology which can affect both the eyes and the brain, and by and large the basal. So you have in sarcoid kind of infiltrative basal meningitis, which will cause raised pressure, will also affect cranial nerve. Seventh nerve is very common. Okay, so in sarcoid patients, so actually young people coming with seventh nerve, you need to rule out a sarcoid diagnosis. Now in this patient, as Rupesh said, we need to look at the other eye. We need to look at the periphery, because we want to make sure we are not dealing with how urgent is, how emergent is the pathology. Are we dealing with a brain tumor? Are we dealing with a raised intracranial pressure? So other eye, what does it look like? If it is good, now we know that it is localized only to the eye, there is no intracranial pathology. Okay, now this swelling, do we look at other signs, like look at, is there a spontaneous venous pulsations? Because venous pulsations are typically lost in raised intracranial pressure. So when you see, well, there is no venous pulsations, are we seeing any peripapillary halo, which we see in patients with raised intracranial pressure? Because that is what we are bothered. Okay, now vision, why is the vision poor in this patient? Is this optic swelling or is it optic neuritis? Because we have to decide on that. Is it inflammation or is it swelling? Swelling per se, papilledema, it doesn't cause loss of vision until late when this optic atrophy sets in. So in this kind of a setting, when you see, is it this pathology which is causing poor vision, 624, or is it macular involvement? Now what is the situation where macular edema is associated with optic nerve edema? Can we have that situation? So can we, intermediate uveitis, does it cause this swelling? A substantial swelling like here? No way. So we believe, and now next we need to know, is this vasculature okay? Are there any abnormal vessels? Now abnormal vessels, when we start seeing on the nerve pad, we think in terms of sarcoid, because sarcoid granulomas, they're vascular, they would have elements of new vessels on the optic disc. Okay, so looking at this disc, we come to, and you see the configuration of these hard exudates, which fits in more like, are we looking at a neuroretinitis? So neuroretinitis is where you have inflammation of the optical head. When you do a fluorescent angiogram, I don't expect any leakage of the perifoveal capillaries. So if I don't see leakage in the macula, and I see this the hard exudates, the way they are distributed in macular fan configuration, I would think in terms of a neuroretinitis caused here, and he has given you a clue that the girlfriend's cat,
Is the girlfriend or the cat?
or the cat, either of them, could have, scratched, typically. So we are now thinking in terms of, is it a Bartonella, infection, which typically causes what we call bacillary angiomatosis. It will cause GI infection. You might have this bacillary angiomatous lesion even in the stomach, because of the Bartonella infection. So typically it produces angiomatous reaction on the optic nerve head. They become leaky. and you have this kind of situation. So let's hear now.
So
What does
you
he-
mentioned, so I want to go back, so Dr. Gupta just took you to the process of that, and you came up initially with diagnosis of toxoplasmosis based on the finding that's there. So now you go back, that thing, based on what he just said, and based on the fact that we discussed also yesterday when I showed that picture with the optic nerve involvement along with the X-ray in there is regional neuroretinitis. Do you think toxoplasmosis can give you this type of picture? What part of it is no? In other words, is the toxoplasmosis not giving you this type of optic nerve inflammation, or is the toxoplasmosis not giving you this type of X-ray around the macula?
Neuroretinitis is rarely found in toxoplasmosis actually.
Correct. So that's what he meant. The doctor will give you some very good hint and feeling there, because you came up with the toxoplasmosis, which is very possible if you just see this optic nerve alone with that. But with all this macular accident in there, that put the picture together with a neuroretinitis, and therefore the differential diagnosis go much further down for toxoplasmosis. Okay, so I think our learning is that when we first start with this, by not jumping to the conclusion that we all learn, you look at and what we just learned from that is that if you can come up with the description of this that make it a neuroretinitis, because what retina and that, then the thinking is much sharper.
I think that's why I was trying to take you to whether it is choroiditis, to describe it's a right-sided unifocal choroiditis. If it's a multifocal, then you say right-sided multiple choroiditis patches. Automatically, once you said that, your half of the diagnosis is done. No one with that kind of thing, they will fail you in the exam. So in case if you're giving for the exams, no
Never
one.
make a spot diagnosis, whatever the prompting by the examiner. You go in a sequence, examine them in that sequence, and then you come up with a description. And then you try to fit that description. I think somebody has gone over how to reach, no?
Yeah.
I think
Naming and meshing,
Right.
they have gone over, I think.
And I'm glad that everyone is learning. This is part we are learning this. I think this is very important to take things and to get together. Sometimes we think that we go right to the diagnosis, but it's actually very good. Just like in any conferences, when people ask you to discuss the fundus, you don't quite go away to this aspect. You start so you won't forget. This is the fundus of the right eye. The knee is clear. The optic nerve show this. The macula, the vessel, the periphery. If you keep in that type of thinking, it helps you putting together two and help. But that's okay. I mean, I say what we say, anything happen in Singapore, stay in this room. So just be free and don't get the outside.
Okay, let's move to the next candidate, Andra. Oh, great. Okay, so your mentor is, so I'm moderator. Professor Quan is on call. You are getting a patient now. Okay. So let's not get into the other details of it. What we wanted is a description and all those things. He treated with doxycycline for 2 full weeks, no additional steroid, and got better. You know? Okay. Okay. So you can present your case, which is a 41-year-old male British patient, a 3-week history of decrease in the vision in the right eye, no redness, no history of injury or drug intake, history of rheumatoid arthritis on oral prednisone and oral methotrexate. History of bitten by a cat again, a few weeks ago. Okay, more or less the same case. Looks like, okay? Same presentation. Okay, never mind. Just go forward.
Now, I just want to,
Sorry.
I just want to highlight one issue here, because somehow it has gotten into literature that cat scratch disease resolves spontaneously.
Yeah.
Okay, so that you don't need to treat these patients. Okay, so I would like to mention here that this disease is notorious for causing arterial occlusion. It can cause venous thrombosis, it can cause a bronchial occlusion, it can also cause a cilioretinal artery occlusion or a branch retinal artery occlusion. So it's good to treat this patient rather than wait for spontaneous resolution. You know, I have seen disasters happening, waiting for it to resolve spontaneously, the patient lost vision, you know, because of the arterial occlusion, and then they chase you because, doctor, I came to you, you know, there was no arterial occlusion, how the hell I've got arterial occlusion now and lost vision. So you have to, I would treat them, you know, when effective treatment is studied.
Especially since the treatment, the risk for treatment is so low, because this antibiotics is a very straightforward doxycycline. Or what happens if the patient is allergic to penicillin? What's the other option? I'm sorry? Actually, for this one, so if doxy is, if they're allergic to any family of penicillin, the other one will be the quinolone. So Cipro is very well known for this aspect. Cipro is also used in case of renal insufficiency as well for that. So the treatment here is just the antibiotics and this antibiotics. So I fully agree with Dr. Gupta this that we should treat because the risk of treatment is so low. If you don't treat, you get all this vascular occlusion, and that's even more of a headache to deal with.
And how much is this CAT and association? Is it really like that, or can be? Because sometimes you do not get that history. Here we are writing that, but is that really something? Is that?
No, you know, I have been stabbed by a cat. I didn't develop.
No, not that way, but as it other way around.
These cats, you know, even the kittens, small, you know, they very quickly they have this infection, and they are some kind of host for Bartonella, and you know, in their feces they excrete Bartonella. So if the cats are moving around, you know, you have your pots and pans, and you know, they would be contaminated with this bacteria. Okay, so I don't think personally scratch is important.
Scratches.
But cat contaminating your environment is sufficient. You know, the kind of you are not washing your hands or something. You know, you get that fecal you know.
Who has cat at home? Anyone here have cat at home? You can donate your cat after this trip.
Yeah.
Okay.
Now,
Okay, we'll go ahead with your case. Yeah. So sorry, that was the same case. In same means both of us. 48-year-old female complains of decreased vision for few months. History of bilateral acute angle closure, bilateral intermediate and posterior, that is 4 months prior to consultation. You know, the visual acuity in the right eye is 660, 66, slit lamp, antichamber cells, anterivitreal cells. Now over to you. How do you want to explain to him over phone, and then how do you want to proceed further? You can ask him, you can describe to him, and you can tell him. Now in between you and Professor Quan.
The lens is clear. About the systemic history.
Okay. You are calling him and then describing you got a case, this, you know. Just try to describe little bit.
This case about a female about 48 years, complaining decreased vision for few months. With the bilateral intermediate and posterior view uveitis, about 4 months. And the visual acuity, right eye 6/60 and left eye 6/6, and the slit lamp is same.
Okay, so if you have that history of that, what else you wanted to learn about that history? So the history right now said that the patient has a history of intermediate and posterior uveitis. So what do you, before you talk about exam, what do you want to know about that history?
About
treatment.
about the treatment.
Yes, so you want to find out like what exactly how the patient was treated, bilateral, posterior, and then what if she come in, if they know specifically the history of posterior uveitis, that's very rare that the patient know that. But let's just provide that they know actually that. Then you want to figure out how it was treated in the past, right? What was treated, whether there was a diagnosis or not, it was posterior, what part was involved, was the retina, was it the optic nerve, what is the plate that involved? And before you tie it to the current presentation of this. Right? So now let's say, so do we have any gut history at all?
No.
No. Okay, so this patient, she just, that she doesn't have no the detail. So now on this exam here, on this slit lamp, what else you want to know? So you know you have one blood cell, what in there that you want to know? Usually in the case of uveitis, on the slit lamp examination, what else you want to find out?
About the synechia.
Synechia, okay, so there's yes, no synechia.
Then?
There's no, what else? What are things that's special about like sarcoid or TB? What type of other finding that you can tell from the AC exam? The cornea, right? So you want to find out, ask the question whether there's anything deposited in the cornea, what is it? Because that helps you to go for the granulomatous or non-granulomatous reaction, that type of thing. So that will help you in this aspect from there. And then the patient also had a history of ankylosing glaucoma as well, right? So, or at least ankylosing pregnancy, you also want to ask about what the iris, because what happened if this patient and find out to have, let's just say, unilateral sectoral iris atrophy, then what will you be thinking of? If the findings show that the patient has unilateral, for example, sectoral iris atrophy, we don't know if they have, I'm just saying that's what we're thinking, but let's say if they have iris atrophy like this, then what are you thinking of? You have your partner next to you, he's anxious to answer to help you in there. So, yeah, you have a lifeline there.
Yeah.
Right.
Okay, first maybe I want to know from the anterior segment, for the iris, is there any iris nodules? If it has any iris atrophy, I would like to know the pupil condition too, because if there's any like polychoria, we might think further like Axenfeld-Rieger syndrome or else.
You know, you find this is compatible. You know, there's history of intermediate and posterior uveitis and angle closure glaucoma. Of all these, which you think is most believable? Angle closure glaucoma. Okay. Now, can you think of any inflammatory disease which will present as angle closure glaucoma and yet the underlying disease is inflammatory? No, we have not touched this aspect. But VKH, any disease which causes diffuse choroidal thickening, okay, can present as acute glaucoma. So we have VKH, we have acute retinal necrosis, we have, you can look it up, you know, we have described this in Lancet, acute retinal necrosis, which was misdiagnosed. They were treating as angle closure glaucoma till they, you know, brought the patient in. I said, oh my God, this patient has acute retinal necrosis. Uveal effusion syndrome. Okay, many of these patients with choroidal thickness would have ciliary body rotation and pause. Okay, and then you have sarcoidosis. Okay, with so many deposits. So, you know, gonioscopy, I would do a gonioscopy in this patient and look at what's happening in the angle. Do we have those granulomas sitting, you know, beside the KPs? So when you say intermediate uveitis and posterior uveitis, of course, this combination anterior, intermediate posterior uveitis, these combinations are known. That means there is a posterior segment pathology as well as there is a significant vitreous inflammation. Now, I don't expect 1+ vitreous cells to label as intermediate uveitis. Okay.
So, next. Okay. We like to see the retina, right? Describe the retinal changes.
It's both hazy media on both eyes, the optic nerve swelling on the left eye, swollen, but the cup-disc ratio it's cupping, I think, and there are whitish exudates on both eyes, but both on the right eye it was in the temporal side, and the left eye it encircling the macula. But we can still see the artery and vena clearly.
Where is the level of that lesion? You want to describe maybe in the right eye the lesion? Where is the lesion? What is the level of the lesion? What do you think about? So that's something which has to come out in your description. What do you think?
Just start with what you see in that lesion in there. What is that lesion?
It's behind the retina, I think it's choroiditis.
Yeah. Good. And why do you think it is choroiditis?
Because we can still see the vessels above the choroid.
See, contrast. We all live in dark, you know. Yeah.
So you know it's subretinal, right? Whether or not it's choroidal, we don't know yet. We know it's subretinal because the vessel above, just as you point out.
Obstruct.
Yeah. So subretinal, correct? And,
Yeah.
And then what about this lesion? Is it clear border, not clear border? Is it hazy? What?
It's a clear border. Because the hazy media, I think it's quite clear border, but like on the left eye.
No, let's focus on the right eye. Do you think it's clear border?
How many people agree that this is
Clear border?
clear border?
Everyone agree this is a clear border? Raise hands, those who say clear border of the lesion.
If you don't raise your hand, that means you agree, right? I mean, just like in America, if you don't vote, that means you agree with the candidate that you put into the White House and so on. So therefore, you have to speak up and ask like from there.
Then you don't have any right to complain.
Yes, exactly. You cannot complain later and so on.
Now clear.
So, I mean, is it clear or is it not clear? Seriously,
Not clear.
it's not clear. Okay, so your classmate think it's not clear. Okay, so there's the democracy here. So, especially the temporal aspect from there, right? So, this is what did you think? Is this a fluffy type of thing? Okay, it's fluffy. It does. So if you look at this thing, what type of pathology do you think may be going on?
I think it's not infectious.
It's not infectious. How do you come up with that? I mean, go ahead. Share with us your thought. Why would you think this is not infectious?
Because basically, like Prof. Gupta told yesterday, if the lesion or retinitis, we always think that it is infectious, but opposite that, if it's choroiditis, it's not infectious.
So, are you certainly that this is a choroid and not a retinitis?
It might be.
No, it might be me. You have seen. You have to say now, it's predominantly retinal involvement. Is it choroid predominantly? Is it likely that the choroidal lesion is, invading into the retina? And you didn't tell us whether it's reactive or non-reactive. Is there evidence of fluid around it? In distinct borders, and you do see some watermarks here. I have a feeling that there has been a fluid around it, when this picture was taken. So this was a kind of reactive, okay? So you're right, it's predominantly choroidal pathologies are non-infective, whether associated with systemic disease or, without any systemic disease, white dot syndrome. This is not a white dot syndrome. Okay, then you should have described the size of the lesion. You know, so this is a big. This appears to be reactive. This appears to be having not a very uniform elevation. There are areas which are a little depressed. The other areas are more elevated. So my reading of this would be, is it kind of a choroidal granuloma? And your differential would be, is it TB, which has a component of infective, but basically it's a immune reactivity, their immune reaction, or is it sarcoid? So we have to come to that.
Yeah. Is that right? Happy? Is that? You should be able to come out with that morphology. That's what we are trying to say. When you describe, you should be very clear that I am seeing a patient who has cello anterior chamber cells, vitreous cells 1 plus. Otherwise, the media is fairly seen, and there is a single lesion sitting temporal, supratemporal to the fovea, and the lesion is the size of 4 disc diameter with not so clear edges, and then irregular surface overlying. The vessels are overlying it, probably more deep retinal or maybe choroidal lesions. Cannot say, but the vessels are getting obscured. The vessels are obscured. Maybe it is a retinochoroidal, but there is not much of vitritis on it. So automatically you are trying to rule out one by one thing. And then you say the other eye also has some similar lesion, but those are the small one, and the pigmented lesion, those looks like a scar kind of thing. And that is how you describe, so that the picture person in front get a very clear idea what you are trying to describe. You know. Then what will you do next? What is your immediate thing? Now that you described, what have you done? By the time he said, okay, I'm coming, by the time what will you do?
You can pass to your next classmate, unless you want to handle it or
Yeah.
you're allowed to pass it to the back.
Yeah.
If you want, you don't have to, but no, it's okay.
What will you do next?
So I will give him some tests
Okay.
like BDD.
The labs, before the labs, what all you have emphasized yesterday, today?
Toys.
Eh? So much you can do sitting in your clinic.
I will examine the patient again thoroughly, as the mouth, the hair, hand, his posture, like that.
You probably go back and then ask maybe more history and other things, examine and all. Okay, that's a part of a clinical examination. A lot of times in uveitis, remember one thing. Sometimes you see something funny and all those things. Always go back into the history. And based on your examination, before the patient goes out of the clinic, ask many questions which can be asked in this particular case. But not only this, what we are trying to generalize is, anywhere you see anything suspect, you may like to go back into history, go back into your examination, then revise. So that's not like once you're done with the cataract now. This is much different. You have to revise those things again and again. Therefore, electronic medical records are very good because you have a lot of space. Every time you can edit it. With the paper notes, you have to just put one arrow there and all. But in this electronic notes, you can always edit it there, at least on that day. Yeah. Then clinical examination. So there are two types of tests. One is done in the lab, which is not in your control, but there is some test which you can do in your clinic. What will you do?
So at this stage, what would you do in the eye clinic? What other ancillary testing that you can do?
I had to rule out TB and syphilis.
So again, those are tests that you can send the patient, go to the lab and have those tested. However, in the eye clinic right now, what thing that you can perhaps consider testing right now before sending the patient to the lab? So you understand the question? So, you can ask the question, you can do some of the lab, but that you have to send the patient outside the eye clinic. What can you do right now in the eye clinic? In other words, these are just from this photograph that you look, or the eye that you look at. There are things that you can learn more as an ophthalmologist. You can look at. So what other testing that you can ask for right now?
OCT and Brazil and Joran.
why do we do that? Again, the reason is that why do we do that? One is the getting the etiology. Why do we do fluorescein and OCT here? Why?
I will also take.
You do a fundus photo also. I will do a fundus photograph also. Why? Why do you do fundus photo? Why do you do OCT? Why do you do an angiogram? What is the basic reason?
Photography because we had to document
Why?
and follow up the patient.
Follow up.
Yeah.
Not for publication of the paper. That may be one of the things.
No, that's
Okay?
important.
That's very important. That's very, we all publish, but yeah, that's one of the things. But again, that is very important documentation. Because how much you can describe in your finding in the EMR or anywhere. It is very important where you, that is a very important education tool for any patient, for yourself also. But tomorrow another colleague, he can follow. Very important photograph. Okay, next. What is the reason of doing OCT? Why?
OCT to see the location of
Very good.
the lesion
Yeah, the depth of the lesion, the extent of the lesion, the associated findings with that.
and to see there if there was CME in the fovea.
Associated complications and all. Fantastic.
And yeah, I can see some subretinal fluid rich in the
Fantastic.
gland, so
Fantastic,
I can
Sid.
follow.
But you required a clue, prompting. So this should come spontaneous. If you have to be prompted to come up with this, you will not do it in the clinic when you're seeing the actual patient. It will never occur to you. So try to develop all these things as a spontaneous reaction when you are looking at a patient.
That was very important. Okay, so OCT to know the extent of the lesion. Same thing, angiography. Why do you do angiography? Extent and activity of the lesion.
Yeah,
That will tell you whether the lesion is active.
liquids of the
And sometimes you can say OCT, FFA and all these things may define you a character, a pattern, which may help you kind of thing in coming up with a diagnosis also sometimes. Okay, the pattern recognition and all those things. So that is why you need to do all these tests. It's not just not because that we want to do it. We have to have a good reason. Okay, so this is one. See, this is where you can see what is happening. Again, we are not getting into the details of it. I just probably want to show one more case. But as you can very clearly see, you were seeing one lesion. But suddenly you can start seeing two things.
So in addition to the lesion, right, what happened to the optic nerve there? The optic nerve is also lit up here as well, too, right? So the optic nerve is somewhat inflamed as well. The big lesion temporarily you saw, but at the same time you see a few more smaller lesions around the fovea, which in actually in the way you recall the images on the left eye also have some of those lesions. So it seems like this is a bilateral process and going on, and that you have thing over there, this aspect. And at this moment, again, it's hard to tell whether this lesion is strictly choroidal or subretinal or a mixture, because so far it's only showing this. Ideally, if we can get the OCT all the way over there, the eye tilted a little bit, then you can look at it, but we don't know yet. We just see that they are active. Now look at this, very hard.
But you see the left eye, this is the FA, and you see the ICG. This is very good slide which can show you how many pictures this ICG can show you, which was probably not seen on the FA or on the color photo. There are many more lesions which were seen, so it's a very good role. And that is why sometimes you have to go for some of this test. Okay, this is something, sorry, OCT is not there for this.
Okay, so the testing come back and on these, so
When Fernando was positive, he was started also on anti-TB, but it took a while. And because by the time physician started oral steroid and then the anti-TB. But will not, yeah, wait.
I was going to say, so your point, your colleague next to you, Dr. Gupta mentioned yesterday that if it's choroidal, it's not an infection like it, but you have to watch out, like some of this TB, he also mentioned that it can be a mixture. So you cannot just completely rule out an infectious process. And in fact, when the V gets hazy like this, and a lot of times it's often indicate that infection is a possibility in there. So I just want to make sure of that.
Okay, let's just move maybe last case.
So it will be pass the case on to you. So you want to
Dr. Ho, can you take control? Your mentor is Dr. Ho here. She's the consultant on call and maybe, huh? Yeah. Why not? Come in front. Come in front. Okay, we'll present the case to you. This is a 22-year-old
You have a chair right here, right next to him, and then you get close.
Very close. Okay.
Just
They will present and then we'll discuss whether they are presenting properly.
And the rest is behind you. This
Rest
is
is behind you.
So,
Okay.
You got the mic? Yeah.
Want me to present?
no,
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 he
no,
will
he will
present.
present to you.
To present to you. And you are on phone. You are on telephone. Okay.
A 22 years healthy male presenting complaints one week history of central scotoma and floaters in the left eye, and he has also a hand brush. Recent month history of travel in Malaysia and Indonesia, a history of camping, swimming in freshwater ocean, bitten by a monkey.
Monkey crab.
Consumption of pork, fish, meat, everything. Nice history of fever, night sweat, weight loss, itchy feet during the last week of travel.
So, want to take a pause here. Why this history is important? Go.
Okay, back to UK 2 weeks ago, started on rabies vaccination, diagnosed with cutaneous lava migrans and tinea on his feet. Hand rash, erythema migrans. Visual acuity, right eye 6.6, left eye 6.18. Color vision normal in both eyes. Slit line exam, anterior chamber deep and quiet both eyes. Lens clear both eyes. Anterior features clear right eye. Trace cells left eye.
you want to show from this picture? You want to ask him?
Yes. Yeah, please go on.
No, no, he's not on microphone. Listen.
Oh, okay.
Yeah,
It's okay. You
take
just go.
this.
Oh, thank you. Yeah. What do you find in the fundus? Oh.
So everything is seem to be in the left eye, yes? No, 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 you keep it. Just walk.
Everything's on the left side. Yeah. What do you find on the fundus?
Normal and in the right eye with a normal limit, and in the left eye there is a. I can see clearly.
Come closer. Come closer.
This is a correlation, I think.
Before you come to the chloride, you see
Yeah.
they are small, big, of this variable size, multifocal, unifocal, describe,
Yes.
Describe it. Yes.
yeah, and automatically.
You can come here. On see on this. It's better.
Okay.
This is better.
It's a learning experience.
You can describe the entire thing. Okay. Describe for me.
This is the nerve is, I think it's not, no? Oh no.
I want to know the abnormal part.
In the choroid there is a multiple.
Are you sure that's on the correct? Are you sure that's on the correct? I just want to
Systemic-
describe.
systemic-
You have to tell me the layers because you have to see the 2D picture here. Describe what you see exactly. That's enough.
The telemedicine going on. So you're seeing through the telemedicine and you're seeing real patient.
Just go start with the nerve. Start from the beginning. Like at the media, the nerve, the macula. That's supposed to see.
The media is clear. The media is clear. The optic nerve.
Maybe not as clear as the right eye. You know, this the trace media is, so that will show that when there is a vitreous inflammation,
There is an.
you know, it's very important to have that
Okay, yeah.
information.
Yes. I think.
What is the most outstanding abnormality you notice on the left eye?
The multiple,
Most outstanding.
Yeah, say that, multiple.
the multiple granuloma.
No, you
Sorry.
don't say granuloma, you're not seeing granuloma.
Okay.
You're seeing clinically flat, 2D, you know,
Uh,
the variable size, same size, uniform, not uniform, borders, clear, distinct, indistinct. It went through vessels, overlying, underlying, you know, they're
Okay.
obscured.
Let me guide you. Where do you find the abnormality?
Just
Where?
At the-
find out.
Fundus.
You
At the
find
fundus.
out.
I'm on the phone. At the fundus, where do you find abnormality?
Here?
Well, I'm on the phone. I'm not saying here.
She says she's on the phone, you cannot say here. You have to describe it because she cannot
Isn't it?
see.
Yeah,
or
I
see.
don't have the picture around me. So you tell me, where is it abnormal?
There is multiple
Uh-huh. Uh-huh.
blue spot. No.
Okay, I want description. Do you see a lot of
What is-
white lesion? And how big are they? Are they fluffy edges? Do
They
you
are-
see a lot of white lesion? What are the color of the lesions and their sizes? Roughly.
Whitish lesion.
Uh-huh.
The size is not.
Well, the size you can compare it with this side, I
Mhm.
mean, this area. I mean, you can use the size at the half this area or the small.
less than
Yeah.
half the disc.
Yeah, and then multiple.
And multiple.
It's variable. You can say this is varying from 200 microns or 100 microns to 300 microns or 500 microns. You know, what is the shape? They are not any specific shape. Borders are distinct,
I'm going to ask
not
you a question.
or indistinct.
Is there macular edema then?
There is a macular edema. There is a macular edema.
I see. Is the disc swollen?
This, yes, I think swollen little bit, yeah.
A little bit.
Yes.
This is a bit swollen. And are the vessels okay?
Vessels. There's a flavis.
It's okay. If you're not sure, that's okay as well.
That's
And
not-
from my point of view, have you done any investigation on the patient so far?
So, if you have to sum up by now,
Mhm.
what are the positive storyline in this patient? What is the, you need to break them into keywords. I call them keywords. Okay, they'll give you an idea of what you're dealing with. So you have to, separate, grain from the chaff.
Mhm.
What is grain, what is chaff, which you need to throw out. So garbage you throw out. So he told, is it related to meat eating, pork eating, or whatever you said, everything? Is it related to that? Is it related to his hiking trip, or he was going around in the forested area? Then, he has been to, in the area, he's a tourist. So we should be asking, did he have any sexual contact with the commercial sex workers or something like that? Because from UK, he's loafing around in the, Southeast Asia. So these are the critical components. Then the important is, he gave history of rash on the palms, and the feet, and also the migrants, erythema migrants. Now when you put them together with a picture where you see multifocal retinitis lesion, little bit of the vitritis, the differential diagnosis is just two entities we will think. What are those two things which you'll have in mind so that you can order for definitive laboratory tests?
In my
So
opinion,
his behavior before coming back to UK, and there is a positive in that, very significant positive history. What does it point to? What is the significance
This
of palmar
infection.
rash?
I think it's a.
You ask the patient open mouth, you ask the patient to show their palms, you know,
There's a rice.
secondary syphilis. Okay, you think in terms of secondary syphilis. You see these lesions, retinitis, multifocal retinitis lesions, vitritis, you think in terms of syphilis. But does it produce erythema migrans? When you talk of erythema migrans, you are thinking he has been going around in a forest, hiking or whatever, camping in the forest, he said, you know, you get what?
Bitten by.
Yes.
Bitten by. Forget. Bitten by monkey.
No, that was the history saying, but
Yeah.
when you travel around the forest, what else did you be bitten by?
Okay. Mosquitoes.
So you mosquitoes, but there are other, you know, which stick to the skin, infect you with Borrelia. So so we are talking of now a spirochetal disease, be it is syphilis or be it is Borrelia. So Lyme disease is the one which will have these two, and we will order specifics for that. So
Maybe we'll get one of the experienced person, Chitranjan, from the area where all these things are there. Come, Chitranjan, just resolve this case quickly. Help your colleague. Come, you have seen, I think, maximum number of those cases in Madurai. This kind of stuff you see. Okay, come. Quickly. Just describe and sum up. Thank you. Let's sum up.
Some of the positive points from the history and from the picture what I can see, he gave a history of scotoma, and there was, as it is pointed out, there were larva migrans history was there, and here we can see in the left eye there are multiple whitish grey lesions are there, and mild temporal pallor is also there left eye. So can it be deviation?
yes.
Deviation.
Yes.
Diffuse unilateral subacute neuroretinitis, because the larva keeps on changing his position, and wherever he moves it, the lesion like that area becomes hypopigmented grayish picture, and maybe in early stages it may not be helpful, but still can we advise ERG to see? Sometimes it is.
No, before that you would like to do an angiogram, you would like to see whether there are transmission defects, and you know, palmar rash, I won't see it in Duchenne. And people who develop Duchenne, they don't get erythema migrans. So I would still go by the differential. If at all, if this fellow had fever or there was an epidemic going on, I would think in terms of chikungunya, you know, which can produce like retinitis here, and they would have again the rash, but they would have significant history of fever and passing through, you know, traveling in an area which is endemic.
On this picture, but I see it. Yes, in the OCT we can see there is a minimal thinning of the layers, and there are some elevations in the RP table. You can see small elevated lesions.
Syphilis was also one of the differential diagnosis, not written here. But syphilis was also kept as but these were the differentials. Okay. Thanks. Thanks. Basic idea was not to get through the cases, but just to how do you describe. I think this is again one of those similar kind of patient where you can see this a few funny lesions here, and you can see some leakage here. And again, in this patient, the same diagnosis was made. But this lesion was first patient was started on steroids, and you can see this how it disappeared. Particularly.
So in this case, the serologic testing, what is positive in here?
No, there is no particular serology was kind of done to arrive at the diagnosis of that EUSM.
By the time you see this, do you
See,
expect
usually you need to
to
see the nematode.
Yeah, in the
And it's a, S shape or something, while, it would go deep, it will disappear, come back. And the current location of this parasite would be given by intense reaction there. It causes intense infiltration there, and then it moves away, and it gets healed, and you have some kind of tiny scar there, and keeps moving very, very rapidly, here and there. And these days, rather than treat it on albendazole, you would like to locate this and laser it, kill it right there. But this is a very, shifty kind of parasite, so you have to really locate it and shoot it.
fast.
Yeah.
When you laser it, do you also need to give some systemic steroid for that? Because it-
No, I don't think they need
I'm
steroids.
just wondering, is it because
Yeah,
It
it's
can
a
be
very
used.
tiny. I think they're different sizes, but usually it's about 200, 300 microns, So tiny thing, but locating it, if you know where to look for, and Don Gas has given a lot of description how to chase. I think all his life he was chasing Susan, and unilateral disease, and he ultimately did find these nematodes on, meticulous examination and laser it. Probably that's the only laser he did in his life, killing these nematodes.
Okay, I think with that we have a lot of brainstorming, and this one will go on. But first, I'd like to thank the young participants for coming out and really great effort. It's not easy to speak in front of and when you're not seen. I think thanks, and really appreciate all your efforts. And then thanks to our panel of moderators and faculty. Thank you very much for all this. With that, a lot of brainstorming. I think time to relax, and we'll give over to Lucy to do the final other things. Yeah. What should we do? Are we distributing certificates?
okay,
Will you
we'll
get-
call by country. Let's
Will you
call by India and then
You want someone to give Professor Quan can give?
fine.
I thought last week don't they have to take an exam first before you get
Yes, that's why this year they got to make this easy.
Okay,
Right, you have to take an exam.
we'll call your name and then you can collect your certificates from Professor
Let's
Quan.
see the feedback. Okay, when your country is being called, give your feedback form to me, get your certificate and USB, and I can go photo.
We call Chitranjan Mishra. Thank you, Chitranjan, coming from Madurai. Thank you. We wish you a safe flight back.
Okay, go stand there, take photo. Which you can
Professor
choose.
Quan, you can give certificate.
I think we should stand with the okay.
One, two, three, smile. Smile. Okay. Okay, I check, make sure I open. Okay, very good.
Good.
Okay, Indonesia, I think you got as a group.
Indonesia as a group, we have
Okay, go as a group.
Nur Syamisi Ahmed,
How many?
Hendra.
Five, four, five.
Hendra, Arif, please come. And then we have Eddie. Is that okay? Yeah, please come, all of you.
You can stand
Then
here
take
and I
the
can take the photo.
Dr. Gupta, please
Dr.
join us.
Yes?
Dr. Hu.
Okay, come join us.
We'll flank you. Come. You have the VIP.
Okay, and you have to move closer, closer, and closer. One, two, three, smile. One more time, smile, look here straight, smile. Okay, very good, thank you.
Thank you, all of you. Malaysia is a bigger group, 6 people from Malaysia.
Space, please.
Yong Gang Ying, Wong Chi Lun, Primala Devi, Hanin, Dr. Ko Kun Ling,
No feedback.
LC
Oh,
Fun.
certificate.
Dr. LC Fun. Yeah, please come.
You got give feedback form? They say you got certificate.
So no feedback form, no certificate.
Yeah, thank you very much. Sorry, Up to you, you want the whole or not? It's
And
up to you.
good feedback form, good certificate.
Good feedback form for USB.
Okay.
Okay, got it. Okay, let's move behind.
Come. No,
Why are you running away?
Okay, you can come together, please.
Moderator, you have to be part of the.
Yeah, stand here is very good. Okay, move
they'll
closer
remember
to
you,
each
huh?
other and look here and 1, 2, 1, wait, okay, 1, 2, smile. Okay, one more time, smile. Everybody can do happy to me. Yes, you're very hard today. Okay, done. Thank you.
Thank you. Now, lone candidate from Nepal, Sanjeev.
Oh, you can take 1 with 3. Can.
Sandeep, come.
Come, 1, 1, 2, 3, smile. One more time, and right here. This looks better. 1, 2, 3, smile. Okay, thank you.
Now, local, Singapore.
Mr. Singapore, please.
Dr. Loon Sang Chi, I think he's left for the
Yeah,
day.
you have 2 left.
Lillian, please come. Paul,
Lillian can. She's 2.
Paul.
Yeah.
Jengxian is not here.
Yeah.
So you came.
Yeah. Only 2 left.
So you came. And Yusin also left. Huh? Only 2 left. Huh?
Okay, so closer. Closer. Let's look neat and tight. Okay, 1, 2, 3, small. Yeah, try one more like that. 1, 2, 3, small. Okay, thank you.
Okay, Taiwan. Yu Xuan Wang
Okay, never mind. I will be free for you.
and Lian Chia. Lian Chia, please come.
I will be free for you.
Good feedback, bad feedback. Bad the certificate. Huh? Come, Taiwan.
Make sure you check the things that correct. That's good.
Okay. Yeah. Okay. 1, 2, 3, smile. 1, 2, 3, smile. Okay.
Thank you. The best.
Island 2.
Island. Okay, we'll see you in Bangkok soon for APO. Chayaport and Dao Liu. Please come.
Okay, 1, 2, 3, smile. Okay, one more time. 1, 2, 3, smile. Yeah, I saw the thumb. Okay, good. Okay. Ready, Dr. Here.
Yeah, you're the only one.
Yeah.
Vietnam.
Okay, 1, 2, 3. And 1, 2, 3. Okay, that's it.
Thank you.
Yeah.
Okay, everyone done? Am I missed someone?
Did anyone come up? Would anybody miss anybody? No?
Anyone got 2 certificates?
Yeah.
Okay.